Hello everyone, good evening and welcome to this session of FMGE Accelerate Ophthalmology. So please let me know if I am audible and visible and you are able to see the presentation. Please let me know if I am audible and visible and then we can go ahead with the presentation with the class. I hope you are able to see me and hear me. I'm audible and visible and the presentation is also visible to you. So shall we start with the class? Okay. So like yesterday, today's session also we will be doing in the form of MCQs only. And as we have finished we finished about 35 PYQs yesterday, we will be doing the rest of the PYQs today. But before that, I want to do a few one-liners which I think are very, very important as far as FMG exam is concerned. So in FMG exams, we still get a sizable number of one-liners, and I believe that one-liners are something which we can never get wrong, and it like takes you like 10 to 20 seconds to answer the question if you know it. But if you don't know it, like it's lost. So first, let's go through these very important one-liners that we have, and then I will complete the rest of the questions from yesterday's PYQ session. So let me start with this. Look at this. Tell me, the epithelium of the cornea is, what is the epithelium of the cornea? Is it a cuboidal epithelium, columnar epithelium, stratified squamous keratinized epithelium, or stratified squamous non-keratinized epithelium? So which one of this should be marked? The epithelium of the cornea is cuboidal, columnar, stratified squamous, keratinized, stratified squamous, non-keratinized. So which is the correct answer here? Which one will you mark? A, B, C or D? Epithelium of the cornea is? Chalo, quick. These are one-liners. We should get the answers immediately. Okay, so the answer is the epithelium of the cornea is stratified squamous non-keratinized epithelium. Stratified squamous non-keratinized epithelium, right? Now a couple of more one-liners from here. Now in case of xerophthalmia, what is xerophthalmia? Xerophthalmia is, it happens in vitamin A deficiency. In xerophthalmia, there is a change of this corneal epithelium to stratified squamous keratinized epithelium. So there is something which is called as metaplasia. So there is a metaplasia of the epithelium to stratified squamous keratinized. This is the second one-liner. So normally the epithelium of the cornea is a stratified squamous non-keratinized epithelium, and in xerophthalmia it changes to stratified squamous keratinized epithelium. Remember both these questions. Let's go to the next one. Where do we get to see HT spots? Horner-Trantas spots are seen in. Where do we get to see Horner-Trantas spots? Flictanular conjunctivitis, vernal keratoconjunctivitis, trachoma, or adenoviral conjunctivitis. Where do we get to see HT spots? Horner-Trantas spots are seen in. Chalo, quick answer. Where do we get to see HT spots or Horner-Trantas spots? Right, Horner-Trantas spots are seen in vernal keratoconjunctivitis, VKC, or spring catarrh. So what are the things, other things that are seen that you have to remember about VKC? Cobblestone appearance. So cobblestone appearance of the tarsal conjunctiva, Horner-Trantas spots, shield ulcer. All these are seen in VKC. All these are seen in VKC. So cobblestone appearance, shield ulcer, HT spots. Tell me, where do you get to see Arl's line and Herbert Spitz? The same options if I give you. Where do you get to see Arl's line and Herbert Spitz? Again, very commonly asked MCQ. Where do we get Arl's line and Herbert Spitz? Which one will you mark here? Arl's line and Herbert Spitz, they are seen in. Arl's line and Herbert Spitz, where are they seen? Where do we get to see Arl's line and Herbert Spitz? Correct, they are seen in trachoma. So Arl's line and Herbert Spitz are seen in trachoma. Okay, Let's go to the next question. Where do we get to see Fleischer's ring? Fleischer's ring is seen in. So Fleischer's ring is seen in pterygium, keratoconus, pellucid marginal degeneration, or granular dystrophy. Fleischer's ring. Fleischer's ring is seen in pterygium, keratoconus, pellucid marginal degeneration, or granular dystrophy. What is the answer here? What is the Fleischer's ring basically? The Fleischer's ring, this is a pigmented ring at the base of, it is a pigmented ring due to iron deposition. It is a pigmented ring which is caused by iron deposition, which is there at the base of the cone in keratoconus. So Fleischer's ring, you know, yesterday we learned what's keratoconus. It's a protrusion of the cornea. At the base of that cone, there is a pigmented ring because of iron deposition that's called as keratoconus. And line, Stocker's line is also a pigmented line due to iron deposition, and this is seen in pterygium. So don't forget these two questions, okay? So both Fleischer's ring and pterygium, they are caused by deposition of iron. Fleischer's ring is seen in keratoconus at the base of the cone, and Stocker's line is seen at the head of the pterygium. Okay, so don't get this wrong. Next question. Let's go to the next question. What is the refractive error in keratoconus? Again, common MCQ. What is the refractive error that you get to see in keratoconus? So there is a protrusion, there is a localized protrusion of the cornea like this, and it is associated with thinning also. So what is the refractive error you get to see in keratoconus? It's a protrusion of the cornea associated with thinning. Is it hypermetropia, simple hypermetropic astigmatism, irregular myopic astigmatism, or compound hypermetropic astigmatism? So what's the answer? What do we get to see in keratoconus? Yes, it is irregular myopic astigmatism. So it's a myopic astigmatism and it is irregular, meaning it is not associated, doesn't have any particular pattern. So irregular myopic astigmatism, this is the refractive error in keratoconus. So please remember this, again important question. Phacomorphic glaucoma is caused by, again many times this has been asked and it is also likely to be asked again. Phacomorphic glaucoma is caused by, is it caused by nuclear cataract, mature intumescent cataract, hypermature sclerotic cataract, or hypermature Morgagnian cataract? Which type of cataract causes phacomorphic glaucoma? So what is phacomorphic glaucoma? In phacomorphic glaucoma is caused by which type of cataract? Nuclear, mature intumescent, hypermature or hypermature Morgagnian? It is caused by mature intumescent cataract. Correct. It's caused by mature intumescent cataract. So in a mature intumescent cataract, what happens? The swollen lens, it pushes the iris forward and it closes the angle, giving rise to glaucoma. So there is a swollen lens which is called as a mature intumescent cataract, which pushes the iris forward and causes glaucoma. That is called as phacomorphic glaucoma. Now, will you be able to tell me which type of cataract causes phacolytic glaucoma? This is also commonly asked. Which type of cataract causes phacolytic glaucoma? Which type of cataract causes phacolytic glaucoma? Phacolytic glaucoma is caused by which of these? If we give the same options, then the answer is hypermature Morgagnian cataract. So in hypermature Morgagnian cataract, the liquefied cortical proteins, they leak out and they block the angle, giving rise to phacolytic glaucoma. This is also called as lens protein glaucoma. So phacolytic glaucoma or lens protein glaucoma is caused by hypermature Morgagnian cataract, and phacomorphic glaucoma is caused by mature intumescent cataract. Again, another very commonly asked and important question. Let's go to the next one. Where do you get to see posterior lenticonus? Lenticonus means that the surface of the lens is conical. So this is posterior lenticonus, and if the same thing you have anteriorly, that's called as anterior lenticonus. So where do we get to see posterior lenticonus? Any idea? Please learn this up. Posterior lenticonus is seen in Lowey's syndrome. And anterior lenticonus, if we talk about anterior lenticonus, where the anterior surface of the lens is conical, anterior lenticonus, this is seen in Alport's. So posterior lenticonus is seen in Lowey's and anterior lenticonus is seen in Alport's. So remember it as A for A. Okay, so please remember this as A for A. Anterior lenticonus is seen in Alport's, and posterior lenticonus, this is seen in Lowey's syndrome. This is seen in Lowey's syndrome. Okay, again two common questions. Let's go to the next one. Where do we get to see sauce and cheese retinopathy? Now, the other name for sauce and cheese retinopathy can also come in the exam. It is called as pizza pie retinopathy. So, sauce and cheese retinopathy, also called as pizza pie retinopathy. In which condition do we see it? See, what are the options given to us? Toxoplasmosis, HSV retinitis, cytomegalovirus retinitis, or sarcoidosis. So, sauce and cheese retinopathy or pizza pie retinopathy, where do we get to see this? Any idea? If you don't know, learn this up. Again, a common question. Sauce and cheese retinopathy or pizza pie retinopathy. This is the typical description for cytomegalovirus retinitis, which is seen in HIV AIDS patients who have very low CD4 counts. So AIDS patients with very low CD4 counts tend to have this sauce and cheese retinopathy or pizza pie retinopathy due to CMV retinitis, due to cytomegalovirus retinitis. Okay, next question. Where do we get to see Dallen-Fuchs nodules? Dallen-Fuchs nodules. So Dallen-Fuchs nodules, these are typically seen in which of these conditions? Sympathetic ophthalmitis, Vogt-Koyanagi-Harada disease, ankylosing spondylitis, or sarcoidosis. So in which condition do we get to see this? Any idea? Any of you know? Correct. Dallen-Fuchs nodules are seen in sympathetic ophthalmitis. Dallen-Fuchs nodules are seen in sympathetic ophthalmitis. Oh, so what is sympathetic ophthalmitis? There are like 3 or 4 MCQs to be learned from here, I'll tell you. Sympathetic ophthalmitis is seen when there is a severe injury to one eye, as a result of which there is a uveitis which develops in the other eye. So there is a severe uveitis, and suppose I get a trauma in this eye and a uveitis later develops in this eye, that is sympathetic ophthalmitis. So from here, the question that is asked is, which type of trauma causes sympathetic ophthalmitis? So please remember, it is penetrating injury. So penetrating trauma, but not to any part of the eye. Penetrating trauma to the ciliary body, to the region of the ciliary body. So when there is a penetrating trauma to the area of the ciliary body, that may gives rise to sympathetic ophthalmitis, meaning there is a severe injury in this eye and then a severe uveitis develops in the other eye. So penetrating trauma to the area of the ciliary body. So when you have a severe trauma to this eye and you are suspecting that there may be a development of sympathetic ophthalmia in the other eye, so you have to monitor the other eye. So we have to know what is the earliest symptom and what is the earliest sign. So please memorize these two also. The earliest symptom is difficulty in near vision due to loss of accommodation. So difficulty in near vision due to loss of accommodation, this is the earliest symptom. So we have to tell the patient to monitor the near vision in the other eye. So difficulty in near vision due to loss of accommodation, this is your earliest symptom. And the earliest sign, this also you have to memorize. This has come a couple of years earlier. Retrolental flare, meaning flare means haziness and retrolental means behind the lens. So haziness behind the lens or retrolental flare, this is the earliest sign. So which kind of trauma causes sympathetic ophthalmia? Penetrating trauma. To which part of the eye? To the ciliary body. What is the earliest symptom? Difficulty in near vision due to loss of accommodation. And what is the earliest sign? Retrolental flare or haziness behind the lens. And what kind of nodules do you see? You get to see Dallen-Fuchs nodule. Also, in one slide we have discussed like 5 or 6 one-liners. Right? Shall I go to the next question? Chalo, let's go to this. Where do we get to see 100-day glaucoma? Some people also call it 90-day glaucoma. 100-day glaucoma or 90-day glaucoma, where is it seen? Is it seen in CRAO, CRVO, retinitis pigmentosa, or Stargardt's disease? Where do we get to see this? Where do we get to see 100-day glaucoma or 90-day glaucoma? Where do we get to see 100-day glaucoma or 90-day glaucoma? Very good. It is seen in CRVO. So in CRVO, two things you have to remember. Typically the appearance of the retina, this is called as splashed tomato appearance. Typically the retina, this is called as splashed tomato appearance, and if it is left untreated, then what may happen is that after a period of about 3 months, so it may end up getting neovascular glaucoma, which is called as 100-day glaucoma or 90-day glaucoma, typically because it's happening after a period of 90 to 100 days. That's about 3 months. Okay, so what is the appearance? One question, that is the splashed tomato appearance, and after 3 months you tend to get this end stage neovascular glaucoma if it is left untreated, and that's called as 100-day glaucoma or 90-day glaucoma. Right, so let's go to the next question. Where do you get to see Harb's striae? Again, another very common question. Where do we get to see Harb's striae? Do we get to see it in ophthalmus, keratoconus, myopia, or trauma? So Harb's striae are actually stretch lines or striae on the cornea. Where do we get to see them? Is it ophthalmus, keratoconus, myopia, or trauma? Where do we get to see Harb's striae? So Harb's striae, yes, they are seen in ophthalmus, that is congenital glaucoma. Correct. So Harb's striae, they are typically seen in ophthalmus or congenital glaucoma. Correct. So these Harb's striae, they are stretch lines in which layer of the cornea? So please remember, they are stretch lines on the Descemet's membrane. This is also asked. They are stretch lines or striae on the Descemet's membrane of the cornea, and they are typically horizontal in direction. They are horizontal in direction. All these are asked. So Harb's striae, they are stretch lines or striae on the Descemet's membrane of the cornea, typically horizontal in direction. Now, will anybody of you be able to tell me where do we get to see Voigt's striae? The same options if I give you. Where do you get to see Voigt's striae? Ophthalmus, keratoconus, myopia, trauma. Which condition do we get to see Voigt's striae? Which condition do we get to see Voigt's striae? Voigt's striae are seen in the same options if we are given. Then Voigt's striae are seen where? Yes, Voigt's striae, they are seen in keratoconus. They are seen in keratoconus. Okay. And these Voigt's striae, they are also striae on the Descemet's membrane. So this is also on the Descemet's membrane, but please remember that these Voigt's striae, they are vertical in direction. They are vertical in direction. So Harb's striae we remember as H for H, and Voigt's striae we remember as V for V. So Harb's striae, where are they seen? Harb's striae are seen in ophthalmus or congenital glaucoma. Voigt's striae are seen in keratoconus. Okay, again another important question. Let's go to the next one. What is the most common cause of unilateral proptosis in children? What is the most common cause of unilateral proptosis in children? Proptosis, I hope you know what is proptosis. Proptosis means protrusion of the eyeball. Protrusion of the eyeball is called as proptosis. So what is the most common cause of unilateral proptosis in children? This has been asked once previously. So is it thyroid ophthalmopathy, chloroma, orbital cellulitis, or retinoblastoma? What is the most common cause of unilateral proptosis in children? So most common cause of unilateral proptosis in children, very good, it is orbital cellulitis. So most common cause of unilateral proptosis in children is orbital cellulitis. Now, what is the most common cause of unilateral or bilateral proptosis in adults? It is the same. Unilateral or bilateral proptosis in adults. What is the most common cause of unilateral or bilateral proptosis in adults? Will you be able to tell me this? This is again a very simple and often asked question. For adults, the most common cause of proptosis, whether it's unilateral or bilateral, is thyroid ophthalmopathy. It is thyroid ophthalmopathy, right? So most common cause of proptosis in children is orbital cellulitis, and it is unilateral. For adults, whether it is unilateral or bilateral proptosis, the most common cause is thyroid ophthalmopathy. Okay, let me go to the next one. Tell me which is the most common intraorbital tumor in an adult. Mind you, I am not talking about ocular tumors, not tumors inside the eye. We are talking about tumors in the orbit. What is the most common intraorbital tumor in an adult? What is the most common intraorbital tumor in an adult? This is a slightly difficult question, so I will answer it for you. The most common intraorbital tumor in an adult is cavernous hemangioma. It is cavernous hemangioma. Please learn this. The most common orbital tumor in an adult is cavernous hemangioma. It's a benign tumor. It's a benign tumor. Most common benign intraorbital tumor in an adult. This is cavernous hemangioma. Now, if I ask you what is the most common benign intraorbital tumor in a child? The most common benign intraorbital tumor in a child. It is dermoid. Please learn this also. The most common benign intraorbital tumor in a child is dermoid. Most common benign intraorbital tumor in an adult is cavernous hemangioma, and most common benign intraorbital tumor in a child is dermoid. Now the next question that I'll ask you, I think everybody will be able to say. Tell me, what is the most common intraocular malignancy in an adult? Most common intraocular. Now we are talking about ocular, that is inside the eye. The most common intraocular malignancy in an adult is choroidal metastases. It is choroidal metastases. And if I ask you what is the most common intraocular malignancy in a child? What is the most common intraocular malignancy in a child? This everybody should be able to answer. What is it? Most common intraocular malignancy in a child? It is retinoblastoma. So these also two important one-liners which I think you should be able to remember. So most common intraocular malignancy in a child is retinoblastoma, and most common intraocular malignancy in an adult patient is choroidal metastasis. Okay, chalo, let's go to the next question. What is a sty? Again, common and very commonly a very important question. What is it? Is it an acute infection of the gland of Zeiss? Is it an acute infection of the meibomian gland? It is a chronic inflammation of the gland of Zeiss, or is it a chronic inflammation of the meibomian gland? Now please remember that sty is what? Sty is also called as एक्सटर्नल हॉर्डियोलम. स्टाई को हम एक्सटर्नल हॉर्डियोलम भी बोलते हैं. So the sty or external hordeolum, what is it? Is it an acute infection of the gland of Zeiss, meibomian gland, or is it a chronic inflammation? Correct. It's an acute infection of the gland of Zeiss. Very good. So acute infection of the gland of Zeiss, this is called as a sty or external hordeolum. अब बाकी भी सीख लो. Acute infection of the meibomian gland, what is this called? This is called as internal hordeolum. What is it called? It is called as internal hordeolum. So acute infection of the gland of Zeiss is a sty. Acute infection of the meibomian gland is internal hordeolum. And a chronic granulomatous inflammation of the meibomian gland, this also has been asked multiple number of times. This is called as a chalazion. What is it? It's a chalazion. So a chronic granulomatous inflammation of the meibomian gland, this is called as a chalazion. So these three questions are again very important. Okay, I'll go to the next one. Where do you get to see leash nodules? Where do we get to see leash nodules? Are they seen in Down syndrome, Marfan syndrome, neurofibromatosis 1, or do we get to see them in myotonic dystrophy? So where do we get to see leash nodules? Okay, I'll tell you, leash nodules are typically seen in neurofibromatosis 1. This is very important. So leash nodules are seen in NF1 or neurofibromatosis 1. Okay, so these are, I will be sharing this PDF as after the class is over. So this is actually, these are the one-liners that I wanted to discuss with you. Now we will go and we will discuss the rest of the questions from yesterday's class. So we had finished up to question number 35, I believe, and we have a few more questions to go. So just give me a couple of minutes. Okay, so I think we had done up to question number 35. So now let's go to this question. So these are the questions, the PYQs, which I had discussed yesterday, and the rest. So let's look at this question. A child presents with fever, pain and swelling of the eye, not eyes, of the eye. On examination, there is proptosis and there is severe lid edema. What is the most likely diagnosis? So see, the child is presenting to us with fever, pain and swelling of the eye. There is proptosis and there is severe lid edema. So you can make out from this picture, see the lids are very swollen. There is severe lid edema. The conjunctiva is congested and chemosed. There is congestion and there is also chemosis, meaning the conjunctiva is edematous also. And what do you see? You see proptosis. Proptosis means that the globe is protruded. And see, in these conditions, it's very difficult to open the eye. And if you were to open the eye, you will see that the eye movements are also affected. So what is the likely diagnosis? Very good. So it is orbital cellulitis. So acute suppurative inflammation, that's an acute infection of the orbital soft tissues or orbital cellulitis, which is like the most common cause of unilateral proptosis in a child. We learned this just a little bit ago, so that is the answer here. Okay, so let's go to the next question. A 60-year-old diabetic male. So this question, elderly, diabetic, these two words are important. He has a history of breathlessness, fever, tachypnea, malaise. His RT-PCR report shows that he is positive for SARS-CoV-2 virus. And on day 10, there is bilateral orbital swelling and proptosis. What could be the causative organism? So see, basically this is said, what is important is that there is an elderly patient who is a diabetic and he is positive for COVID. So now these patients, he has a history of breathlessness, fever, etc. And many of these patients are often given steroids. So elderly patient who is a diabetic, who is positive for COVID, most probably given steroids. Then later on he develops bilateral orbital swelling. So what is the answer here? Correct. The causative organism is mucor. So mucormycosis. So this is basically mucormycosis. So orbital infection with mucor, and this is one of the complications that was seen in during the COVID period, where steroids were had to be administered to severe cases of COVID patients, especially elderly patients and diabetic patients. Okay, so these are the pointers in the questions: elderly, diabetic, severe patient of COVID, and then after a few days, they have not mentioned steroids, but that also may be mentioned, he develops eye swelling and proptosis. Let's go to the next one. A patient presents with blunt trauma to the anterior part of the lens. So what kind of cataract is he likely to develop? So the question is blunt trauma. So the type of cataract, that is traumatic cataract. What kind of traumatic cataract is seen if you have a blunt injury? So the options are rosette cataract, sunflower cataract, posterior subcapsular cataract, or zonular cataract. Correct. So the answer is rosette cataract. I'll just show you an image. So have a look at this image. This can come as an IBQ also. So look at this cataract. See, it's like a flower shaped cataract. A flower shaped kind of a cataract. This is typically the rosette cataract that you see in blunt trauma. So these kind of a flower shaped cataract. Okay, now let's just quickly go over the other options. Where do we get to see sunflower cataract? Does anyone remember? Where do we get to see sunflower cataract, by the way? Where do we get to see sunflower cataract? Sunflower cataract is seen in Wilson's disease. And in Wilson's disease, what do we have? Wilson's disease, this is due to the deposition of copper, right? So there is deposition of copper, and this gives rise to what is called as your sunflower cataract. Okay, so rosette cataract in blunt trauma, sunflower cataract in Wilson's disease. Now, will anybody be able to tell me where do we get to see Christmas tree cataract? This is also another commonly asked question. Where do we get to see Christmas tree cataract? In which condition is Christmas tree cataract typically described? In which condition do we get to see typically Christmas tree cataract? Christmas tree cataract, this is seen in myotonic dystrophy. So these three important one-liners, please remember. So rosette cataract is seen in blunt trauma, blunt injury. Sunflower cataract is seen in Wilson's disease. Christmas tree cataract is seen in myotonic dystrophy. Now tell me, where do you get to see snowflake cataract? If you get snowflake cataract, what option will you say? Where do we get to see snowflake cataract? Which condition do we get snowflake cataract? Snowflake cataract is typically seen in diabetes mellitus. So diabetes mellitus, we get to see snowflake cataract. Okay, so these are a few important one-liners about the different types of cataract. Chalo, let's go to the next question. Which laser is used in laser-assisted cataract surgery? So in laser-assisted cataract surgery, which is the modern form of cataract surgery, even more supposed to be better than the phacoemulsification cataract surgery. It's a step ahead. So which is the laser used in laser-assisted cataract surgery? Is it excimer laser? Is it diode laser? Is it femtosecond laser or ND-YAG laser? Sorry, this is ND-YAG. Is it excimer laser, diode laser, femto laser or ND-YAG laser? The answer is femtosecond laser. Femtosecond laser is used in cataract surgery. So femtosecond, the name of the surgery is FLACS. That is femtosecond laser assisted cataract surgery. Femtosecond laser assisted cataract surgery. Femtosecond laser assisted cataract surgery, that is FLACS. FLACS. Femtosecond laser assisted cataract surgery. So just learn this up. Femtosecond laser, it has two important applications. So femto laser, where all is it used? In two important applications in ophthalmology. One is FLACS, which is a type of cataract surgery, right? And it is used in smile surgery. What is smile surgery? Smile surgery is a type of refractive surgery. That is, it is called as small incision lenticule extraction. Small incision lenticule extraction. Smile surgery, that is small incision lenticule extraction. So these are two important applications of femtosecond laser. And where do we use ND-YAG laser? I think yesterday I told you ND-YAG laser has got two important applications. What are they? It is used in laser peripheral iridotomy. It is used in laser peripheral iridotomy. Where do we do laser peripheral iridotomy? I hope you remember laser peripheral iridotomy is done in ACG, that is angle closure glaucoma, it is done. And ND-YAG laser is also used in laser capsulotomy, which is done for PCO, that is posterior capsule opacification. PCO or posterior capsule opacification. So let's just go over this once more. See, important applications of femtosecond laser are FLACS, which is laser assisted cataract surgery, and smile surgery, which is a type of refractive surgery. So this is a type of refractive surgery. Right? ND-YAG, its applications are laser PI, that is done in angle closure glaucoma, and laser capsulotomy, which is done in PCO. And do you remember we had learned yesterday where is excimer laser used? What is the important application of excimer laser in ophthalmology? Where is it used? What is the important application of excimer laser in ophthalmology? Okay, I'll tell you, excimer laser, this is used in LASIK, which is the most commonly done refractive surgery. So LASIK is done with the help of excimer laser. So these are the important lasers and their applications in ophthalmology. This slide is very, very important. Please memorize this. Okay, chalo, let's go to the next question. A 65-year-old male who has undergone cataract surgery a year back is now complaining of diminished vision, and on a slit lamp examination, this is what you see. So you see that there is an IOL and there is this area appears to be white. So what is the cause of this vision loss? Is it Irwin-Gass syndrome? Is it after cataract? Is it UGH? Or is it endophthalmitis? Irwin gas after cataract, UGH, or endophthalmitis. What is the cause? So see, there is a patient, the catch in the question is that the patient has already undergone cataract surgery. So, but then also see the area, that is the area at the center of the pupil, it's appearing whitish, and that is the cause of diminished vision. Why it is appearing whitish? Because the posterior capsule has become opacified. So this is what the answer is. PCO, posterior capsule opacification. Now, posterior capsule opacification is the new name. What is the old name for this condition? The old name for the condition is after cataract. Okay, so see the behind the IOL, the posterior capsule that is left behind, and in cataract surgery we remove the cataractus lens, but we do not remove the capsule, because inside this capsular bag only the IOL has to be placed. So if the capsule behind the IOL it becomes opaque, that's called as PCO, posterior capsule opacification. That was the old name. Now, sorry, that's the new name. The old name is after cataract. So what are you going to do? We are going to make a cruciate opening here at the center with the help of laser, so that that portion will become clear and the light will be able to pass through. So this is called as laser capsulotomy, which I was saying. So what is the treatment? The treatment is laser capsulotomy. And laser capsulotomy is done with which laser? We just learned it is done with ND-YAG laser. So posterior capsule opacification, also called as after cataract, this is treated with this. Okay. Let's go to the next. Okay, so you're asking how about Irwin gas syndrome? This is not the presentation of Irwin gas syndrome. So see here, you can see they have given us a clinical picture. You can see that there is this shiny reflex. The shiny appearance at the center is coming from the IOL. And behind the IOL, this whitish thing that you see, that is the capsule which is opacified. Let's go to the next question. Where do you get to see ectopia lentis? Now, what does this word ectopia lentis mean? Ectopia lentis means that the lens is in abnormal position since birth. Lens is in abnormal position since birth. Lens is in abnormal position since birth. That is called as ectopia lentis. So where do we get to see ectopia lentis? Homocystinuria, Refsum's disease, Wilson's disease, or sarcoidosis. Homocystinuria, Refsum's disease, Wilson's disease, sarcoidosis. Where do we get to see? Correct. The answer is homocystinuria. Homocystinuria. So what are the important causes of ectopia lentis that we have to remember? The most important or the commonest cause is Marfan syndrome. So the most common cause of ectopia lentis that you have to remember is Marfan. Then is what you saw in the question, that is homocystinuria. Please memorize these. The third is Weil-Marchesani syndrome. Weil-Marchesani syndrome. So Marfan syndrome, homocystinuria, Weil-Marchesani syndrome, hyperlysinemia, Stickler's disease, Stickler's disease, sulfite oxidase deficiency, sulfite oxidase deficiency. So these are important causes that you have to remember. So Marfan syndrome, homocystinuria, Weil-Marchesani syndrome, hyperlysinemia, Stickler's disease, sulfite oxidase deficiency, of which Marfan is most important. And in Marfan, what is the position of the lens? It is not in the normal position, but where is it? Please remember that in Marfan syndrome, the position of the lens is superotemporal. This also comes as MCQ. The position of the lens in Marfan syndrome is superotemporal, and in homocystinuria, it is exactly the opposite of Marfan, that is, it is inferonasal. So in Marfan syndrome, it is superotemporal, and in homocystinuria, it is inferonasal. So these are also asked as MCQ. So if we are asked what is the most common cause, it is Marfan, and what is the position, it is superotemporal. Okay, so these are the important causes of ectopia lentis, that is, lens is in abnormal position since birth. Let's go to the next question. Which of the following is the most common presentation of Marfan syndrome? See, this is like a corollary of that question. Which of the following is the most common ocular presentation of Marfan? So, keratoconus, retinitis pigmentosa, subluxation of the lens, or rosette cataract. Or rosette cataract. So, what will you say here? Which of the following is the most common ocular presentation or ocular feature that you get to see in Marfan? Is it keratoconus, retinitis pigmentosa, subluxation of lens, or rosette cataract? We just learned it. The answer is subluxation of the lens. That is, the lens is in abnormal position since birth. So, subluxation of the lens, ectopia lentis. That is the most common ocular presentation of Marfan syndrome. And we just learned what is the position. It is superotemporal. Correct? Sure. Next question. A patient presents with jaundice and tremors, and there is this finding in the eye. So what is this? Is it Huntington's chorea? Is it Wilson's disease? Is it heavy metal poisoning, or will we call it Sydenham's chorea? So what is this? The patient, what are the points given in the question? There is jaundice. So there is involvement of the liver, there is neurological involvement in the form of tremors, and you get to see this kind of a concentric ring which is close to the limbus. What is this? Slightly yellowish or greenish in color. So there is jaundice, which suggests liver involvement, hepatic involvement, tremors suggestive of neurological involvement, and there is ocular involvement in the form of this kind of a pigmented ring which is concentric to the limbus, which is like yellowish or greenish in color. Correct. So this is Wilson's ring, Wilson's disease. And what is this ring? This is your KF ring, Kayser-Fleischer ring. So this is the KF ring which you get to see in Wilson's disease. So there are two important ocular features in Wilson's disease. Then what are they? One is this KF ring. This KF ring is due to the deposition of copper in the Descemet's membrane. So please remember this, that why does this happen? This happens because of the deposition of copper at the level of the Descemet's membrane. And the other ocular feature we also learnt of Wilson's disease, that is sunflower cataract. Sunflower cataract. So KF ring and sunflower cataract. Okay, chalo, let's go to the next question. So the next question is, a patient has a visual acuity which is greater than 1/60 but less than 3/60 in his better eye. What is the blindness? So the visual acuity, that is the best corrected visual acuity in the better eye, basically that's what this question is trying to say. The best corrected visual acuity in the better eye is less than 3/60. What is this? Is it low vision? Is it economic blindness? Is it social blindness? Or is it manifest blindness? What do we call this? So there are different types of definitions. And the definition always says that it is the best corrected visual acuity, that is the visual acuity with its best possible spectacle correction. So you have to give the best possible glasses to the patient, and you have to check the vision in the better eye, not in the eye which is worse. So the best corrected visual acuity in the better eye, if it is less than 3/60. No, so it is social blindness. So this is social blindness, and this is also one of the criteria for the WHO criteria for blindness. WHO criteria for blindness or social blindness, that is BCVA in the better eye is less than 3/60. But it's important that we learn up the others also. So see, WHO criteria for blindness or social blindness says that the BCVA in the better eye should be less than 3/60. Now see, if the BCVA in the better eye is less than 6/60, then we are going to call this as economic blindness. What is this? This is called as economic blindness. BCVA in the better eye less than 6/60. Now BCVA in the better eye less than 6/18. BCVA in the better eye less than 6/18. This is called as your low vision. This is what is called as low vision. Okay, so BCVA in the better eye less than 6/60 is economic blindness. BCVA in the better eye less than 6 by 18 is low vision, and manifest blindness means BCVA in the better eye is less than 1 by 60. BCVA in the better eye less than 1 by 60, this is manifest blindness. So that's where many of you got confused. So see here it is more than 1 by 60 but less than 3 by 60. So less than 3 by 60 means it is social blindness or it is the WHO criteria for blindness. Less than 1 by 60 would mean manifest blindness. Less than 6 by 60 would mean economic blindness, and less than 6 by 18 would mean low vision. So these four definitions, please learn them very, very well because different things are asked in different exams. Okay, let's go to the next question. What is the most common cause of blindness in children? What is the most common cause of blindness in children? Is it cataract? Is it glaucoma? Is it vitamin A deficiency, that is xerophthalmia, or corneal opacity? Which is the most common cause of blindness in children? Cataract, glaucoma, vitamin A deficiency, or corneal opacity? Correct. It is xerophthalmia or vitamin A deficiency. So vitamin A deficiency or xerophthalmia, this is the most common cause of childhood blindness. But this is childhood blindness, okay? So this is the most common cause of childhood blindness. But if we are asked what is the most common cause of blindness in general, what is the most common cause of blindness in India? What will you answer? What is the most common cause of blindness in India? The most common cause of blindness in India is cataract. Okay. And if we are asked what is the most common cause of low vision in India? What is the most common cause of low vision in India? Now, the most common cause of low vision in India is refractive errors. Errors of refraction which are uncorrected. Okay, so the most common cause of blindness in India, if we are asked, it is cataract. Overall cause, most common cause of low vision in India is refractive error. But if they have mentioned children, that is the most common cause of childhood blindness in India, then the answer is going to be vitamin A deficiency or xerophthalmia. Okay, so these are also commonly asked questions, so do learn them very, very well. Now see, this is again a takeaway from the previous question only. A child with history of malnutrition is examined and the following is noted. What is this? Is it megalocornea, ophthalmos, anterior staphyloma, or corneal degeneration? What is this? This is like a next step to the previous question only. A history of malnutrition, a patient, a child. So this is a child who has history of malnutrition, and there is this is what you see. So what is this? This is an anterior staphyloma basically. This is because of, so we see in xerophthalmia what happens. So there is a history of malnutrition, right? So this malnutrition is actually giving us a clue. This says that there is probably vitamin A deficiency. Now in vitamin A deficiency, in severe cases, what will happen? There will be a corneal ulcer. There will be a corneal ulceration. This corneal ulcer will perforate. The corneal ulcer will perforate and eventually it is going to become an anterior staphyloma like this. This is going to become an anterior staphyloma like this. So in very, very severe cases of vitamin A deficiency, the cornea, it will melt, and when the cornea melts, then you end up with this sequelae, that is anterior staphyloma. So this is an anterior staphyloma. A factory worker gets a trauma to the anterior part of the eye with an iron foreign body. So basically what has happened, there is an intraocular metallic foreign body. There's a factory worker, and what has happened, a foreign body has gone inside the eye, but very, very important is that it's an intraocular metallic foreign body. Now why do we need to investigate? We need to investigate because we want to find out the location of that foreign body. So what investigation will we do? Should we do a CT scan? Should we do an MRI, a USG-B scan, or should we do an angiography for this patient? So what should we do? CT scan, MRI, USG-B scan or FFA? Correct. We have to do a CT scan because it's a metallic foreign body. So if it is a metallic foreign body, MRI is, please remember, it is contraindicated. You should not do an MRI if it is a metallic foreign body. It is contraindicated. We must never do. But where will we do an MRI? MRI, this is investigation of choice if it is a non-metallic foreign body. So suppose it's a wooden particle that may not be picked up in a CT scan. Metallic foreign bodies will be better delineated or better picked up if you do a CT scan. But you must never try and do an MRI if it is a metallic foreign body. So where will I do an MRI? If it is a non-metallic foreign body, like for example, wooden foreign body, a piece of wood has entered the eye and you want to localize it, then that may not be picked up very well on a CT scan. Okay, so please remember, for metallic foreign body, investigation of choice is CT scan and MRI is absolutely contraindicated. For a non-metallic intraocular foreign body, we will do an MRI to localize the foreign body. Okay, sure. Let's go to the next question. A lady presents with ptosis, but on eating and sipping fluid, the ptosis decreases. What is this ptosis? So there is a ptosis. What do we mean by ptosis? Ptosis means drooping of the eyelid. So there is a ptosis, but that ptosis is fluctuating on eating and sipping fluid, meaning with the movement of the jaw. So when the jaw moves, the ptosis is fluctuating. Here they say that the ptosis decreases when her jaw moves. That is, there is on eating and sipping fluid, this actually means jaw movements. Jaw movements. So what kind of ptosis is this? Is it a mechanical ptosis? Is it Horner? Is it complicated ptosis or blepharophimosis? So this is something, if you don't know, it's very difficult to guess. The answer to this is complicated ptosis. This kind of ptosis, it has a name. It is called as Marcus-Gunn jaw winking syndrome. It's called as Marcus-Gunn jaw winking syndrome. Now in this is the type of complicated ptosis where there is a connection between the third nerve and the fifth nerve. So basically this is a complicated kind of condition where the third nerve and the fifth nerve, they are abnormally connected to each other. So what happens is when the fifth nerve fires, the third nerve also fires. So the fifth nerve is supplying these muscles of the jaw. So when the person moves the jaw, that is when the fifth nerve is firing, the third nerve also fires. So it affects the lid movements. So this kind of ptosis, it kind of fluctuates with the jaw movements, and that is called as a complicated ptosis. Here there is an aberrant communication or an abnormal communication between the third nerve which supplies the LPS and the fifth nerve which is supplying the jaw muscles. So this is called as Marcus-Gunn jaw winking syndrome. It's a type of complicated ptosis. So this is like a slightly tough question. Let's go to the next question. On looking through a pinhole, the visual acuity of a patient improves. What is the diagnosis? Is there a macular lesion? Is it a refractive error? Is it amblyopia or is it cataract? So this is the most common test that you do. You ask the patient to read the Snellen's chart. When you see, suppose he's not reading up to the last line, he's reading only a few lines, like he's reading say 6/36 or 6/60. What do? The first thing you do is put a pinhole. And when you ask the patient to read through the pinhole, if the visual acuity improves, that is, suppose it was like 6/36, but as soon as you put the pinhole, you find that he is reading 6/6. So this improvement with pinhole indicates that it is a refractive error. It's a refractive error. This is very, very important. So if it is a refractive error, then the visual acuity with pinhole will improve. But suppose it is, this is what will happen in case of a refractive error. But suppose it is a cataract, what will happen? It is 6/36. Even if you put a pinhole, it will still be 6/36. That is no change. If it is no change, then it is likely to be a cataract. Here it is going, if it improves, it is likely to be a refractive error. And in macular lesion, that is, if there is a pathology which is localized to the macula, then it is going to worsen. It is going to become worse. So if it is 6/36, it may become 6/60. So these are three important things we have to remember about pinhole visual acuity. The commonest thing that you note or you see is that the visual acuity is improving. It was like 636 or 660 without the pinhole, and when you put the pinhole it becomes 6/6. That's the commonest thing that you will see in the ophthalmopedy. That means that the patient has a refractive error. Another thing which you may see in elderly patients is that the visual acuity remains the same. It was 6/36 without the pinhole, it is 6/36 with the pinhole. That means that can suggest a cataract in an elderly patient. And if it is a pathology which is localized to the macula, then it is likely to worsen. That is, if it is 6/36, it may become 6/60 or it may become even less than that. Okay, so this is another important question. The parents of a child complain that he squeezes his eyes while watching TV. What is the probable diagnosis? Is it dry eyes? Is it myopia? Is it hypermetropia? Or is it glaucoma? The parents of a child complain that he squeezes his eyes while watching TV. That is, he's doing like this, squeezing his eyes while watching the TV. So what does this suggest? It suggests what? It suggests what? His distance vision is poor or his near vision is poor? It obviously suggests that his distance vision is poor, right? So the distance vision is affected. And that's why he's squeezing his eyes. So this is suggestive of myopia. And this is typically what you see in children who are in second, third standard, like 8, 9 years old, 7, 8 years old, I should say. That is the time when most of them are brought to us, that they squeeze their eyes while watching TV, or they go close to the TV, or there might be a complaint from the school that he's not able to copy from the blackboard. So this is myopia. What's the other name for myopia? Other name for myopia is short-sightedness. Short-sightedness. Why short-sightedness? The near vision is normal. That's why short-sightedness. The near vision is normal, but the distance vision is affected. The near vision is normal and the distance vision is affected. That is myopia. Right? Now the opposite of this is hypermetropia. What is the other name for hypermetropia? It is far-sightedness. It is called as far-sightedness. Far-sightedness, because it's the opposite. Usually the distance vision is better than the near vision. The distance vision is less affected. The near vision tends to be difficult. So that is hypermetropia. Okay, so in children of about this 8, 9 years old, when they are brought to come with the complaint that they are not able to copy from the blackboard, they squeeze their eyes, they try to go close to the TV, all that is suggestive of myopia, that is short-sightedness. Okay, next question. Where do we use a biconcave lens? So concave lens is used for myopia. Biconcave lens, that is minus. These are minus lenses. Where are they used? Are they used for myopia, hypermetropia, astigmatism, or presbyopia? Where will we use minus lenses? Do we use it for myopia, hypermetropia, astigmatism, or presbyopia? Where do we use these lenses? Correct. Minus lenses or biconcave lenses are used in the treatment of myopia. Minus lenses or biconcave lenses are used in the treatment of myopia. Where do we use plus lenses? Where do we use plus lenses? That is convex lenses. Convex lens, that is plus lens. They are used in hypermetropia, and they are also used in presbyopia for near vision. So in presbyopia, we will also use convex lens, but only for near vision. Convex lens for near vision, because in presbyopia, it is seen in people beyond the age of 40 years and only the near vision is affected. So in presbyopia, we will use convex lenses for near vision. In hypermetropia, we will prescribe convex lenses. And in astigmatism, what do we use? In astigmatism, we use cylindrical lenses. Cylindrical lenses, which may be concave or convex. It can be concave or convex depending on what type of astigmatism you have, but they are a special type of lens which are called as cylindrical lenses. Okay, so convex lenses for hypermetropia and presbyopia, concave lenses or minus lenses for myopia, and cylindrical lenses for astigmatism. Next question. Identify the condition that you see in the image. What is this? Is it an entropion? Is it an ectropion? Is it distichiasis or trichiasis? Is it distichiasis or trichiasis? Entropion, ectropion, distichiasis or trichiasis? Now, if you look at the lower lid carefully of this patient, you will see that the lower lid, it is turned inwards. And because it is turned inwards, that is why these lashes are rubbing on the surface of the cornea. This is called as entropion. So what is entropion? Entropion by definition is inward turning of the lid margin. Inward turning of the lid margin. Inward turning of the lid margin. This is entropion. Inward turning of the lid margin. Now the exact opposite of this is ectropion. What is ectropion? Ectropion is outward turning of the lid margin. It is outward turning of the lid margin. Inward turning of the lid margin, that is entropion, and outward turning of the lid margin, that is ectropion. Now please learn up the definitions of these two also. What is distichiasis? Distichiasis means presence of a second row of eyelashes. Presence of a second row or a double row of eyelashes. This is distichiasis. And what is trichiasis? Trichiasis means misdirected eyelashes. Misdirected eyelashes. Presence of a second row of eyelashes, that is distichiasis, and misdirected eyelashes, that is eyelashes only which are in the opposite direction, that is trichiasis. Okay. So this is, see here it is kind of little bit difficult, but if you look at the lower lid carefully, you will see that the margin is not sharp. It is, you cannot see the, see here you can see this lamella, right? This lamella of the lid, this you cannot see on the lower lid. That's because that lamella is turned inwards. So you should see the lid margin like this. Here you cannot see the lid margin. The lid margin is turned inwards, and that is why the lashes are rubbing on the surface of the cornea. So this is entropion. But if you can see that the lid margin is normal, but still the lashes are rubbing on the surface of the cornea, that is trichiasis. Okay, let's go to the next question. These instruments are used for which condition? They are used for ectropion, entropion, chalazion or bitot spots. For which condition do we use these instruments? So these are the instruments, the images of the instruments are given to us, and we've been asked that in which condition are these instruments used? Are they used for ectropion, entropion, chalazion or bitot spots? Correct. So they are used for chalazion. So see, they are used for INC, that is incision and curettage. They are used for the incision and curettage of the chalazion. Incision and curettage of the chalazion. And this instrument, this is called as the chalazion clamp. This is the chalazion clamp. This is used to fix the chalazion. And this one, if you just look at it, it's like a small scoop. So this is called as your chalazion scoop. So these two instruments, they are used. The first one is the chalazion clamp, which is used to fix the chalazion. Then you make an incision and then you scoop out all the material inside that chalazion with the help of this chalazion scoop. So they are used for INC of chalazion, incision and curettage. Sure. Let's go to the next one. Now, this is something we discussed a little while back. Penetrating injury to which part of the eye is most likely to result in sympathetic ophthalmitis? I told you what is sympathetic ophthalmia, that there is a severe trauma to one eye and in response to this, a severe uveitis is developing in the other eye. So, penetrating injury to which part of the eye is likely to result in sympathetic ophthalmia? Is it the cornea, sclera, ciliary body or extraocular muscles? Very good. We discussed this a little while back. It is penetrating injury to the area of the ciliary body. So penetrating injury to the area of the ciliary body is likely to cause sympathetic ophthalmia. The next question is also something which we have discussed. A 28-year-old man reported within 6 weeks after sustaining a penetrating injury to his left eye. On examination, there is marked diminution of vision in the right eye, right? So, this is a case of sympathetic ophthalmitis. So, what is the first sign that you should look for? So, see, there is a trauma in the left eye. It is a penetrating trauma, then there is a loss of vision in the right eye, and you're looking for an early sign. So what is the early sign you should look for? Congestion, hypopyon, retrolental flare, or iris nodule. What is the earliest sign? The earliest sign should be, we just discussed it, that is retrolental flare. But the retrolental flare will come much earlier than this pain, redness and photophobia, right? So once he has developed pain, redness and photophobia, there is no question of looking at the first sign. So the question probably should have said that what is the first sign that the patient that the doctor should look for. Once the pain, redness and photophobia has come, you will get other signs also, but the earliest sign is retrolental flare. Okay. Which of the following is seen in iridocyclitis? Which of the following is seen in iridocyclitis? RAPD, that is relative afferent pupillary defect, keratic precipitates, disc edema, or ectopia lentis. Now, what is iridocyclitis? Iridocyclitis is acute anterior uveitis. It is anterior uveitis, meaning it is an inflammation of the anterior part of the uvea, that is the iris and the ciliary body. The iris and the anterior part of the ciliary body are inflamed, and hence the name iridocyclitis. So what do you get to see in this? Do you get to see RAPD, keratic precipitates, disc edema, or ectopia lentis? Correct. We get to see keratic precipitates. So what are keratic precipitates? They are basically inflammatory deposits on the corneal endothelium. So they are inflammatory deposits on the corneal endothelium. They are called as KPs or keratic precipitates, and this is seen when you have an acute anterior uveitis. Okay, now I'll take you to the next question. See, this is like a takeaway from the previous question. In uveitis, what is the site of the keratic precipitates? Is it the corneal endothelium? It is the anterior part of the lens, posterior part of the lens, or the corneal stroma. So we just learned what are keratic precipitates or KPs. Keratic precipitates or KPs are nothing but inflammatory deposits on the corneal endothelium. So this is our answer. So see, these inflammatory deposits, they are like this on the corneal endothelium. You will see them, and they are seen in the lower part of the cornea in a triangular area. This area where they are seen, this is called as your Arl's triangle. They are seen on the posterior surface of the cornea, that is the corneal endothelium, in a triangular area which is called as your Arl's triangle. Right? Sure. Next question. So a 32-year-old male is presenting with a complaint of a red and painful eye. You are again suspecting acute uveitis, acute iridocyclitis, iritis, or anterior uveitis in this patient. So what do you see? What do you expect the pupil to be? Do you expect the pupil to be normal, dilated, constricted, or vertically oval? So we have to just quickly go over the features of anterior uveitis here. So what are the features of anterior uveitis? It is pain, redness, photophobia. Pain, redness and photophobia. From the two, three questions that we have read, these are your symptoms. What are the signs? The signs are circumcorneal congestion, that is redness that is surrounding the cornea. Circumcorneal congestion. Then you will have keratic precipitates on the corneal endothelium. Keratic precipitates on the corneal endothelium. Then you will have cells and flare in the anterior chamber. Cells means inflammatory cells, flare means haziness. Cells and flare in the anterior chamber. And the last one, you will have a myosed, that is a constricted pupil because of spasm. Constricted or a myosed pupil because of spasm. So this is what we get to see in acute anterior uveitis. So see, there is pain, redness, photophobia. There is congestion or redness, which is circumcorneal. Then we have learned the very important sign, that is KPs or keratic precipitates, which are on the posterior surface of the cornea. That's the corneal endothelium. We have cells, that is inflammatory cells, and flare. Flare means haziness in the anterior chamber. And we have myosed pupil or a constricted pupil, right, because of spasm. So see, what will be our answer here? The pupil is constricted. In a case of uveitis, we will have a myosed pupil, right? Where do we have a vertically oval pupil? A vertically oval and mid-dilated pupil is seen in acute angle closure glaucoma. Please remember this. This is also MCQ. Acute angle closure glaucoma or acute ACG. That is where you see a vertically oval and mid-dilated pupil. Okay, so constricted pupil in acute anterior uveitis, vertically oval and mid-dilated pupil in acute angle closure glaucoma. Right? Chalo. What is the drug of choice for the management of, not a drug of choice, which of the following is used in the management of acute anterior uveitis? Pilocarpine, brimonidine, atropine, moxifloxacin. Which of the following is used in acute anterior uveitis? Now see, for acute anterior uveitis, the drug of choice is steroids. The drug of choice is steroids because it is an inflammation. The treatment of the drug of choice is steroids. Here what they are asking is, what is the adjuvant drug? What is the adjuvant drug that you will use in acute anterior uveitis? Correct. The answer is atropine, because atropine helps to relieve the ciliary spasm. It relieves the ciliary spasm. I told you, you have a constricted or a myosed pupil because of spasm. So this atropine helps to relieve the ciliary spasm and therefore it relieves the pain. The pain goes away, it relieves the pain. Okay, but if you are asked what is the drug of choice for acute uveitis, the answer is going to be steroids. Steroids are the drug of choice because they help to decrease the inflammation. What is the adjuvant that is to be given? The adjuvant that is to be given is atropine, because atropine is a cycloplegic, meaning it relieves the ciliary spasm and it decreases the pain. Okay, next question. A patient presented in the OPD with anterior uveitis, now it can be associated with which of the following conditions? Actually, this question I feel is a little incomplete. They should have said that it is a young male patient who is presenting with recurrent or chronic anterior uveitis and there is history of low back pain. All this should have been actually mentioned in the question. So a young male patient presents with recurrent or chronic anterior uveitis and he has a history, systemic history is low back pain. Now it can be associated with which of the following conditions? Will you be able to say HLA B5, B27? Correct. The answer is HLA B27 because this is typically what we get in ankylosing spondylitis. We get this typically in ankylosing spondylitis. So, a young male patient who presents to us with recurrent or chronic anterior uveitis, and if you question him, if he says that he has a history of chronic low back pain, and then this is typically tells us that there is a possibility of ankylosing spondylitis and we have to investigate for HLA B27. Okay, next. What is the test that is being done here? Is it the Jones test? Is it the Shermer's test? Is it syringing and probing? Or is it fluorescein staining? What is the test that has been used here? Is it Jones test? Is it Shermer's test? Is it syringing and probing? Or is it fluorescein staining? Or is it fluorescein staining? What will you say? Correct. This is the Shermer's test which is used for dry eye. This is the Shermer's test which is used for dry eye. So what is this? This is the Whatman filter paper number 41. What you do is you fold the paper and you put it in the lower fornix. Where is it put? Essentially it is put at the junction of the medial 2/3 and the lateral 1/3. That is medial 2/3 and lateral 1/3 of the lower eyelid. medial 2/3 and lateral 1/3 of the lower eyelid. Right, and you leave the patient as such, and the patient has to be made to sit in an ambient room. The temperature should be normal, and we have to switch off the AC and the fan, and we have to check it after 5 minutes. And this normally we see that the wetting, how much of that paper has become wet. So if the wetting is more than 15 mm, then we consider it to be normal. If the wetting is more than 15 mm, then that is considered to be normal. So in Sharma's test, if the wetting is more than 15, now 10 to 15 is kind of considered to be borderline. This is considered to be borderline. And less than 10 mm, we will consider it as diagnostic of dry eye. So this is your Sharma's test, which is the most basic clinical test for dry eye. So you take this filter paper and you fold it, you put it in the lower fornix at the junction of the medial 2/3 and lateral 1/3, and you wait for 5 minutes, make the patient sit in an ambient room, as I said, a normal temperature, put off the AC and the fan, and you see how much of the paper has been wetted at the end of 5 minutes, sorry. If it is more than 15 mm, it's normal, and less than 10 mm, it is suggestive of dry. Okay, next test. Next question. Blowout fracture can be due to tennis ball injury, chisel and hammer injury, sudden fall, or punch at the chin from below. Blowout fracture of the orbit. Now, blowout fracture of the orbit, what is this? This is typically, please learn up the definition. It is a fracture of the orbital floor. It is a fracture of the orbital floor without involving the rim. It is a fracture of the orbital floor without involving the rim of the orbit. Correct. And this is typically seen in tennis ball injury, in our country more commonly in cricket ball injury, or it can be seen in fist injury also, that is fights. So tennis ball injury, cricket ball injury, or fist injury. So basically what happens is when there is a large like tennis ball or cricket ball or fist which is covering this at the base of the orbit, there is a sudden increase in intraorbital pressure. So this happens when there is a sudden increase in intraorbital pressure because of this tennis ball, cricket ball or fist injury, and the floor of the orbit gives away. So there's a fracture of the floor, but this rim is spared. So if you palpate here, you will be able to feel the rim, but behind that the floor of the orbit is fractured. So that is called as blowout fracture of the orbit. Okay, next question. Now this is a slightly difficult question, I should say. Which of the following statements about PHPV are true? So first let me tell you what is the meaning of this word PHPV. PHPV means persistent hyperplastic primary vitreous. Persistent hyperplastic primary vitreous. So see, the primary vitreous is actually supposed to disappear during the embryological development. But if that primary vitreous remains, so that is called as PHPV, persistent hyperplastic primary vitreous. So I'll tell you an easy way to remember this. So we remember this as PHPV is remembered typically as A, B and C. It is remembered, it is here. The axial length is decreased. That means it is a small eyeball. The axial length is decreased. Right? Next, this B is presence of bands in the vitreous. Presence of bands. And C is there is prominent ciliary body. Prominent ciliary body. These are the axial length is decreased, meaning that there is microphthalmus. Microphthalmus is small and it is associated with a prominent ciliary body, and there are bands also. It is always unilateral. It's always unilateral. So see, what is true is this, that this is unilateral and it is associated with microphthalmia. Microphthalmia means small eye. Small eyeball. That means the axial length is decreased, right? So this is correct. So this is what is right. So persistent hyperplastic primary vitreous, it is always unilateral. It is associated with a small eyeball, that is microphthalmia. There are presence of bands and there is prominent ciliary body. The prognosis is not very good. So this is what is correct. Okay, let's go to the next question. What is the best treatment for amblyopia? So what is the other name for amblyopia? The other name for amblyopia is lazy eye. What is the best treatment for lazy eye? Usually it may be seen in children who have uncorrected refractive errors in one eye. So if there is an uncorrected refractive error in one eye, refractive error, for example, suppose a child is having say +4 error in this eye or -8 error in this eye and the other eye is normal. So what will happen is over a period of time, the child will not use the bad eye. He will stop using the bad eye and the bad eye will become lazy. That's called as lazy eye or amblyopia. So when you get this kind of child, what do you have to do? What is the best treatment? Occlusion, atropine penalization, correction of the refractive error, or surgery. What is the treatment? The answer here should be actually you have to correct the refractive error and then if it is a refractive amblyopia, you have to correct the refractive error. If it is due to some other cause, you have to first correct the cause and then what you have to do is you have to do occlusion. Occlusion of which eye? Occlusion of the good eye. So the treatment of amblyopia is first correct the cause. Correct the cause or the reason, meaning if it's a refractive error, correct the refractive error. If it is because of a cataract, then operate for the cataract. If it is because of some other cause, then first treat that cause. If it's because of the squint, then first correct the squint. So whatever is the cause of that amblyopia, one of the very common causes is refractive error, but it need not always be because of refractive error. So first you have to correct the cause and the next thing you have to do is you have to occlude the good eye. Meaning if this eye is amblyopic, I will occlude the good eye and I will force the child to use the bad eye. So that bad eye which has become lazy, it will become active again. So treatment of amblyopia is correction of the cause and then occlusion of the good eye. Okay? Sure. This is the last question. When light travels through different media, it undergoes refraction. So the same kind of refraction is seen in the eye. Now, which is the structure in the eye with the highest refractive index? Mind you, they are not talking about refractive power. They have talked about refractive index. So which has the highest refractive index? What will you say? Cornea, lens, aqueous, or vitreous? Okay, I'll tell you the structure with the highest refractive index is lens. So the refractive index of the lens is 1.386. 1.386, yes, roughly it is equal to 1.39. The refractive index of the cornea is 1.376. Okay. The refractive index of aqueous and vitreous humor is 1.336. So for the lens it is 1.386, for the cornea it is 1.376 and for aqueous and vitreous humor it is 1.336. But mind you, this is refractive index. It is not refractive power. If we are asked about refractive power, then the refractive power of the cornea is how much? The refractive power of the cornea is around 44 diopters. And the refractive power of the lens is around 16 diopters. So the highest refractive power is for the cornea, but the highest refractive index is for the lens. So remember these two and please be very careful when you are answering the question. Okay, so for the highest refractive power, it's the cornea because the cornea has 44 diopters of power and the lens has 16 diopters of power. But refractive index is highest for the lens because it's almost equal to 1.39, 1.386. Okay. So these are the questions that I had in store for you in today's session. So over the 2 days, I have tried to discuss the important PYQs and the topics, and also the important one-liners, which I felt that as FMG students going as for the exam, you should be knowing. So just before we end, just a couple of things I would like to tell you. Do read, be confident about your preparation, read well, and do revise before the exams, because if you do not revise whatever you have learned, you may not be able to recall it with confidence. So keep a certain amount of time every day for revision of whatever you have already done. So it's good to keep on learning new things, finishing the topics that you have not yet finished, but at the same time keep a certain amount of your day for solving MCQs and also for revising what you have done earlier, because the more number of times you revise, the better will be the retention and the recall during the exam. Revision is very, very important, right? So thank you very much for attending this session. I will be sharing across the PDF of today's session with the team, and you will be receiving it shortly. So thank you very much. You have been a very, very enthusiastic audience, and all the very best for your exams. Bye-bye.